let's talk about all the other buttons and knobs and stuff on there. Tidal volume. Tidal volume is essentially the safety limit that we set for the patient. Tidal volume is the amount of air that again, the ventilator is going to give with each breath. So you may set it at 300. If you set a tidal volume to 300, that means every time the patient or the ventilator gives a breath, it's going to give a breath of 300 milliliters of gas. We set tidal volume as a safety parameter mostly. This is one that we are mostly going to set and then leave alone because we don't want to mess around with it a whole lot. The reason why is that tidal volume appears to have a big effect on how well the patient's lungs handle this weird type of ventilation. So if you think about the way that we breathe typically, we breathe through negative pressure ventilation. We have a diaphragm, the diaphragm goes down, the space in our chest increases. That means there's negative pressure inside the chest, and so air is drawn in through our trachea, through our airways, and down into our lungs themselves. And then when we release our diaphragm, pressure goes back to atmospheric pressure and stuff goes out of our lungs. When you give somebody a positive pressure breath, like either with a bag or with the ventilator, that is not the way that our lungs were designed to work, and you actually injure them a little bit each time they get a positive pressure breath. And that trauma comes in a number of different flavors. They describe barotrauma, which is pressure. Essentially, you overpressurize the lungs and the alveoli rupture. You could have volutrauma, where there's so much volume that you overdistend the lungs, and the alveoli, the cells literally kind of come apart, and you get shear injury with it. And then when those things happen, you get biotrauma. So when your lungs start to get, kind of ripped apart, you release inflammatory mediators, which cause you to leak fluid into your lungs, and they stop working as well, and a bunch of other bad stuff happens, and you end up with this terrible thing called ARDS. And if you haven't seen ARDS, adult respiratory distress syndrome, this is basically as if you had a terrible pneumonia all through your lungs. And what initially we kind of thought with mechanical ventilation was that if you put somebody on mechanical ventilation, you give them big breaths because that makes their blood gases better, and everything looks better from a parameter standpoint if you give them big tidal volumes. So we were giving breaths at like 15 milliliters per kilogram of body weight with each breath. So you're talking about a liter with each breath, a liter and a half volume with each breath. And you find that anybody that's on a ventilator for any length of time with that, even the course of a day or a couple of days, starts to develop ARDS, starts to develop lung injury as a result of it. Along came in the 90s this group called ARDSNet, which was one of the first groups to actually come up with a way to fix that or to prevent ARDS from happening. And what they found, and what they're actually able to show a benefit to, was not using high tidal volumes of 15 mLs per kilogram. They suggested using a low tidal volume approach. So each breath is only 6 to 8 mLs per kilogram for ideal body weight. And that was associated with better survival, less ARDS, and overall it was safer. This was the first group to be able to fix that ARDS problem. So that's why you keep hearing about ARDSNet or the ARDSNet tables or anything like that. That's where it comes from. So this low tidal volume situation. What that has led us to do is, again, sort of establish the speed limit or the volume limit at 6 to 8 mLs per kilogram ideal body weight for each breath, because that amount seems safe, relatively safe, as safe as you can be for most people. And in order to get more air into the lungs, we increase the ventilatory rate, and we do some other stuff like increase PEEP to help oxygenate better. But we don't give bigger breaths; we give more breaths, or we do other things to help the lungs out, and that is safer for the patient. I mentioned ideal body weight, 6 to 8 milliliters per kilogram ideal body weight. How do you figure out ideal body weight? Well, ideal body weight is essentially the size of, it's going to help figure out the size of your lungs. As you may have heard before, if you have an ideal body weight and your BMI is 22, then your lungs are a certain set size. And it doesn't matter if that guy gains 400 pounds or if he loses 60 pounds, his lungs and his chest cavity are going to stay about the same size. So that's mostly based on height. It's a little bit based on build, but kind of mostly on height. So ideal body weight aims to give you a number so that you don't give somebody too much or too little volume based on the size of their lungs themselves, because lung size is hard to calculate just looking at a person. The easy way to figure that out in kilograms, which is what we're sort of operating in, is if you take their height, the patient's height in centimeters, and subtract 100, that gives you their ideal body weight in kilograms approximately. Now you got to know their height in centimeters first, but that's not that hard to figure out. You could always bring a tape measure with you and figure it out. Women have a little bit of a correction, and it's technically minus 110, but if you just used 100 for everybody, that would be fine. So again, tidal volume, the size of the breath that we're giving to each person, is going to be limited to initially 6 to 8 milliliters per kilogram of ideal body weight. And we're going to determine ideal body weight either through the way that I told you, or there's a formula down at the bottom that you can use if the patient's height is in inches. But this always goes back to kilograms, milliliters per kilogram ideal body weight, 6 to 8 mLs. If you think about what that means, if most of us have a ideal body weight of somewhere around 80 kilograms, if you're an adult male or something like that, 70 to 80 kilograms, 8 mLs times 60 kilograms is 480 milliliters for each breath. That's your tidal volume. So where in the past we used to put people on, again, 600, 700, 1 liter, 1,000 milliliters for each breath, what we should really be doing to keep them safe is something like between 400 and 500 for the most part. If you are really tall and your ideal body weight is 100 kilograms, which again is a really tall person, then they might need as much as 600 milliliters. But again, that is a really big person or really big chest based on ideal body weight. Most of us are going to be somewhere between 400 and 500 milliliters on our tidal volume. If you get far outside that, you better think about what you're doing, because there's a good chance you made a math error wrong in there. How about ventilatory rate? That's usually the next button that we're going to set. We've set our mode, we've set our tidal volume, the amount of volume that's going to go with each breath. How about the frequency of each breath? Ventilatory rate, in terms of what the patient looks like, determines their end tidal CO2, which we are all using on the end of every tube every time we're using waveform capnography. And the thing that determines what your level is, what that number actually is going to be your respiratory rate. So the proof is your CO2 level, your concentration of CO2 in your blood, is determined by how much volume goes in and out of your lungs on a minute-by-minute basis. So your minute ventilation, that's how much air actually goes in and out of your lungs. And that's determined by the tidal volume, which we've already set, and your respiratory rate. So how much at a time and how many times a minute, that gives you the minute ventilation. Thus, what actually determines your minute ventilation, because the tidal volume is set, because we're not going to mess with it, because we don't want to hurt the person, the only thing we can change is your respiratory rate, and therefore your respiratory rate determines your end tidal CO2. That's the proof. Okay, so respiratory rate is determined by end tidal CO2 is determined by your respiratory rate. For most folks, if we're looking at a number, that number needs to be between 35 and 45 on your end tidal CO2. Typically speaking, although there are caveats to that, that's usually going to be achieved with a respiratory rate between 15 and 18 for most people. And again, there's big caveats to that, but if you just need something to start off with, for most people, if your ventilator respiratory rate is between 15 and 18, your end tidal CO2 will probably be between 35 and 45, which is about target. So what's left on most ventilators to set up now is going to be the FiO2 and the PEEP. FiO2 stands for fraction of inspired oxygen, which is the percent of oxygen that you are delivering in each breath. And then PEEP is positive end expiratory pressure. FiO2 and PEEP are joined at the hip, or should be. They're two different knobs, but together they determine oxygenation. And if you think about changing one, you probably ought to think about changing the other one. So you really shouldn't think of them as two separate things because they're both changing oxygenation for the person. They're both eventually changing your SpO2. Let's talk about FiO2, the fraction of inspired oxygen. What percentage of oxygen are you actually getting with each breath? So as you kind of know, this is an alveolus. You got a little capillary that runs around it, and air goes into the center. Oxygen diffuses into the blood cells and sticks to your hemoglobin. CO2 diffuses out of the bloodstream and goes back out into the atmosphere when you breathe out again. If you wanted to increase the amount of oxygen that goes out on these red blood cells here, there's sort of two ways you could do it. One is that you could increase the concentration of oxygen in the alveolus so that more spills into the bloodstream there. There's a higher pressure here and it forces more out that way. The problem is that doesn't work very well. Once you get above about 60% oxygen, usually all the little red cells that are able to pass there will be completely oxygenated. So if this alveolus is open and this is 60% oxygen, for the most part, most of these red blood cells will be fully oxygenated. So it's sort of a brute force thing. You sort of reach the point of diminishing return pretty quickly on that one in terms of the concentration of oxygen. But say the patient's SpO2 is still low. Their SAT's still 80%, even on a 60, 100% fraction of inspired oxygen, FiO2. What do you do then? Well, instead of increasing the amount of oxygen in each alveolus more, what you probably could do is increase the number of alveoli that are participating in gas exchange. And that is what PEEP does. So positive end expiratory pressure is the thing that opens up more alveoli and lets more red blood cells come in contact with the oxygen. Again, above about 60%, we turn FiO2s up all the time, but if you really want to be elegant and actually fix the problem, usually that involves PEEP most of the time. What am I talking about? Well, if you look at your lungs, you find basically three different configurations that the alveoli are in. The alveoli in the bottom of your chest, in the lower lung segments, are generally speaking going to be kind of squished and collapsed, and they don't get a lot of blood flow, and your body knows this, and so it shunts, they don't get a lot of airflow, and your body knows this, and so they shunt blood flow to other places. The ones in the middle sections of your lungs are nicely inflated, and they can get a little bit more in and they can get more out, and they have plenty of blood flow going to them because these are the ones that are really doing a great job at exchanging gas. The ones at the top of your lungs tend to be really open, and if you're getting positive pressure breaths, those guys get really distended. So they get overfilled and sometimes even damaged. So what we want to do is make everybody look like the guys in the center and minimize the amount of extra pressure that we have to put into these guys, which injures them, and we want to increase the number of these guys that are open to participate in gas exchange to get more alveoli in contact with blood and oxygen. So positive end expiratory pressure does that. This is a section of lung tissue. And you see with each breath, the alveoli open and then they close, and they open and then they close. If we add a little bit of pressure, so that's during a breath itself. If you add PEEP, which is a little bit of residual pressure that stays after the breath gets let out, so in this case 5 millimeters of water, you notice that a few more alveoli will stay open. So you don't get that collapse like you did a second ago. And why is collapse sort of a bad thing? Well, it takes a lot of pressure to force open a collapsed alveolus. And if you've got a bunch of alveoli that are already distended, like that one that I showed you there, having to push in more pressure and open each one of those up can cause real problems. So you use PEEP to keep the alveoli open as best you can. And you notice here, now we've basically we keep all the alveoli fully inflated in between each breath. That's what positive end expiratory pressure does. That's what PEEP does. It increases the number of open lung segments so that you can get more efficient use of the oxygen that's coming in. How much PEEP should you be using? I'll talk about this a little bit more, but there are tables that will help you figure that out. And this is by the same guys, the ARDSNet folks, the same guys that did the volume amount. This says if your oxygen concentration is 30%, the patient should probably be on a PEEP of 5. If it's 40%, keep them on a PEEP of 5. If they still need more oxygen, don't increase the oxygen here, increase the PEEP. All right, so we're just about done with all the knobs on there. Just to talk real quick about I to E ratio, which may be one of the other things that you can set up on the vent. I to E ratio is inspiratory to expiratory ratio, meaning how much time you spend in inspiration versus how much time you spend in expiration. And it's displayed as a ratio, so 1:1 means that you spend one part in inspiration and one part in expiration. If you think about the way that most of us breathe as we're kind of sitting here, just take a breath and let it out. Most of us spend more time in exhalation when we are breathing spontaneously than we do in inspiration. So we tend to take a relatively quick breath in and then let it out kind of slowly. So a ratio of 1 to 1.5 or 1 to 1.5 to 1 to 2 is where most of us kind of sit as we're breathing spontaneously. That's a reasonable place to put people when you're putting them on the vent initially. An IDE ratio of 1 to 1 in a completely spontaneously breathing person feels a little bit weird because you want a faster breath given to you, and then you want more time to exhale for the most part. Now that may change if you are heavily sedated and ventilated. The mechanics of it may actually be a little bit more beneficial if you go closer to 1 to 1. If basically you need more support from the ventilator or you have less respiratory drive, an IDE ratio closer to 1 to 1 may be better. If you have obstructive lung disease, an IDE ratio of maybe 1 to 4, where you need much more time to exhale, may be beneficial to you. So for most of us, again, if you had to pick something, 1 to 1.5 or 1 to 2 in a person that you don't know otherwise is a reasonable place to kind of get started with it. But that's IDE ratio.